Diabetes, one of the most dreaded disease in the world today, consuming hundreds of lives as we speak. But diabetes is just the tip of the iceberg. It's the underlying threats of diabetes that compromise and complicate the patient's wellness. The need of the hour is a therapy that offers wellness beyond diabetes control. In TAS, leaders in cardiodiabetotherapy unveils a new era of wellness for diabetes patients, introducing an innovative and holistic approach beyond glycemic control and emphasize heart and kidney protection. Dapavel, wellness beyond diabetes control. Indian phenotype T2DM patients in particular have multiple risk factors and are at high risk of cardiorenal complications. Transform their harsh reality into healthy possibility with Dapavel. Dapavel offers powerful glycemic control. Large studies have shown cardioprotection and renal protection with or without diabetes with dapagliflozin. Every sales pack of Dapavel shares your precious advice with the patient. Uncomplicate your diabetic patient's life with uncompromising quality and efficacy. It's time to offer them hope beyond possibilities, health beyond limitations, happiness beyond expectations. In T2DM with multiple risk factors, prescribe Dapavel. Wellness beyond diabetes control.
Good evening, everyone. On behalf of Intas Pharmaceutical Limited, I, Dr. Mithilesh Nayak, welcome you all to this 5th edition in the webinar series Spotlight SGLT-2 meter. Today we are going to discuss about the cardiorenal syndrome and the role of SGLT-2 meter in the cardiorenal syndrome. And to guide and moderate today's session, we are having with us Dr. H.N. Mishra. He is the Senior Consultant Cardiologist at Apollo Hospital, Bhubaneswar. He is ex-professor and HOD Cardiology at SCB Medical College, Cuttack. He is Fellow of ACC, ICC, ESC, SCAI, and past President of Indian College of Cardiology. And he is having rich experience of over 3 decades in the field of cardiology. So we are fortunate to have with us Dr. H.N. Mishra, sir. So without wasting much time, I am hand over the session to you. Over to you, sir.
Thank you very much. Can you hear me?
Yes. Yes, sir, you are audible.
So, good evening, everybody, and welcome all the speakers and the participants, delegates. We are going to hear an important topic, that is cardiorenal syndrome, which is a topic of interest to the cardiologist, to the physicians, to the nephrologist, and to the diabetologist, endocrinologist. So this is to my mind, it's a cardiorenal syndrome is an enigma, and many things are not understood yet completely. And we have a lot of therapies, and the new therapy, that is the SGLT-2 inhibitors, has come as an important tool for the management of cardiorenal syndrome. And we'll be listening to two important speakers. Dr. Thomas Alexander will be speaking on the pathophysiology of cardiorenal syndrome, and Dr. Kher will be speaking on the management part, especially with special reference to SGLT2 inhibitors. So as all of us know, cardiorenal syndrome encompasses a spectrum of disorders involving both heart and kidneys, in which acute or chronic dysfunction in one organ may induce acute or chronic dysfunction in the other organ. It represents the confluence of heart-kidney interactions across several interfaces. These may include hemodynamic crosstalk between the failing heart and the response of the kidneys, and vice versa. Further, alterations in neurohormonal markers and inflammatory molecules play an important role in its clinical characteristics. So Dr. Thomas will be speaking on the pathophysiology of cardiorenal syndrome, and you will be definitely talking about the various types, namely type 1 to type 5, and we'll be listening the pathophysiology, which to my mind is very complicated, but we can hear him. He will simplify this so that we can understand the pathophysiology. And after that, we'll have Dr. Vijay Kher, who will speak on the pharmacological approach to the cardiorenal disease in diabetes, with special reference to this newly approved drug, that is the SGLT2 inhibitors. So without wasting much time, let me introduce Dr. Thomas Alexander. He is head of cardiology of Kovai Medical Center and Hospital, Coimbatore. He is the course director of STEMI India and Africa STEMI Live. He is the founder director of STEMI Care. He is the faculty at various national and international cardiology forums and member of ACC and AHA. He has published numerous research papers in various peer-reviewed medical journals, participated as a principal investigator in many clinical trials, and over and above which, he is a good friend of mine. So I am happy that we have Thomas Alexander to speak on the pathophysiology of cardiorenal syndrome. Over you, sir.
Thank you, Dr. Mishra. Thank you to Intas for this opportunity to discuss this very important topic. And I think hopefully as we go along, I think both participants and the faculty will learn how not just to diagnose, but also to manage this. So as Dr. Mishra was talking about cardiorenal syndrome, it's broadly defined as a disorder of the heart and kidneys, where it could be either acute or chronic in one organ, inducing a similar dysfunction in the other. And there are multiple areas of interaction. So there is a hemodynamic crosstalk, which we all recognize, between a failing heart and the response to the kidneys, or it could be the other way around. But there is also very significant neurohormonal and inflammatory changes that also mediate this disorder. So it is a bidirectional insult. Mortality is increased in anybody who's treated heart failure. Whenever the GFR falls or the creatinine goes up, we know that we are in trouble, not just in managing these patients, but they tend to have a much worse outcome in terms of both readmissions as well as mortality. We know that mortality is increased by approximately 15% for every 10 ml reduction in eGFR. And the other way too, we know that CKD patients have both atherosclerotic cardiovascular disease as well as heart failure. And it's a very significant risk factor for their patients as well as for heart failure. And we know that 50% of patients with CKD ultimately die of cardiovascular disease. Now, the burden we know is significant in our heart failure patients. We know that there is about 30 to 60% of patients have abnormal kidney function in the population that we treat for heart failure. And we know that about 30% of those undergoing treatment, either for acute or chronic heart failure, develop increases in serum creatinine during the course of their treatment. And this is really a management, a really significant problem in managing these patients. So how do we classify this? And there are 5 types. We talk about CRS type 1, which is essentially an acute heart failure resulting in acute kidney injury. And this is most often a patient who comes to us, say, with cardiogenic shock or acute heart failure. And many of these patients, our management at that point is difficult because a patient in shock, we might need to take this patient to the cath lab, give him contrast, and clearly these are issues that worsen the acute kidney injury. So that's type 1. So this is an acute cardiorenal syndrome, acute cardiac acute heart failure resulting in acute kidney injury. Many of these patients would recover. The second type, or type 2 cardiorenal syndrome, is chronic CRS. These are patients, chronic heart failure patients, who are being treated, and as the LV function deteriorates and we increase the doses of diuretics, or some of these patients have atrial fibrillation, go into heart failure, and we give them medications to control that. Each of these, we see that at the end of that, the cardiac function deteriorates and their creatinine tends to go up, and you results in a progressive chronic kidney disease. And these situations, you find that the kidney function, sometimes it might be an acute or a chronic, but there is progressive worsening of kidney function. Type 3 and type 4 are the reverse. That's acute renocardiac syndrome and acute kidney injury resulting in acute heart failure. Most often what happens is there is volume overload related to acute kidney injury, but there is an inflammatory and a metabolic disturbance, which also we see affects the cardiac function or LV function and would also contribute to acute heart failure. Most of these patients would recover when the acute kidney injury resolves and the patient's kidney function returns to normal. Type 4 is chronic renocardiac syndrome, typically CKD patients, and the typical uremic cardiomyopathy that we see in many of our patients, some of which return to normal once a patient has a transplant. We often find that these patients, if continued still on dialysis, the LV function does not return to normal, but very often after transplant return back to normal. There might be other additional issues like uncontrolled hypertension, LVH, that could also add to the chronic heart failure. And finally, type 5 is secondary cardiorenal syndrome, and these are disease processes that affect both the heart and the kidney, and could be amyloidosis, sepsis, cirrhosis. So this is how one classifies CRS. Who are the patients at risk? These are patients who have pre-existing CKD. We know that it could result in worsening of their kidney functions or an acute or a chronic CKD. Diabetic patients, patients on high dose of diuretics, those who given iodinated contrast, and typically these are patients who present with ACS already in having LV dysfunction, and you take them to the cath lab, and at the end of it, you find that you need to take them up for dialysis. Older age group, those with anemia, prior history of heart failure, or uncontrolled hypertension. Now, what is the prognosis? Now, if you were to look at the CHARM trial, and this showed that the all-cause mortality increased significantly when the eGFR fell, and it was independent of the LV ejection fraction. And continuous, and there was a increase in the reductions in LVF below 45%. The SOLVE study again showed very similar results, except that patients who were on AC inhibitors, the worsening was not associated with increased mortality. as compared to the placebo group. So AC inhibitor certainly has a role to play in this. But again, I think as many of us see, there is a reluctance once the creatinine goes above 2.5 for people to use an AC inhibitor. Now, looking at the pathophysiology of this, I think it's there are multiple pathways, and we talked about the hemodynamic pathway, the neurohormonal pathway, and the inflammatory pathway, and these are very closely interlinked. We know that reduced renal perfusion results a decline in cardiac output of as much as 20% can take place, and this can result in renal perfusion issues. But reduced cardiac index is not the primary driver for renal dysfunction. In fact, some of these patients, even though they have a normal cardiac index, the GFR continues to worsen. So clearly, that's not the primary cause. What has been shown more often is that there is an increased renal venous pressure, both intra-abdominal as well as the central venous pressure. And this reduces the intraglomerular pressure gradient. This reduces that, and the GFR continues to drop. And this may be the most important hemodynamic effect that is responsible for cardiorenal syndrome. Now, looking at it the other way, whenever there is a kidney dysfunction, there is an increase in volume. There is RV dysfunction that takes place, and because of the close interdependence of the ventricles, that there can be associated LV dysfunction. Now, the neurohormonal adaptation, primarily sympathetic nervous system, the RAS activation, and arginine vasopressin, all three of them, we know it gets activated when there's heart failure. And these, by its effect on the kidneys, can result in renal dysfunction. And this is important for us to remember. And some of the therapy is directed at these agents. And finally, we know that the inflammatory markers, the tumor necrosis factor alpha, IL-1, IL-6 are increased in acute kidney injury. And if you take uremic cardiomyopathy, typically type 4 cardiorenal syndrome, has been shown to be causally related to the fibroblast growth factor 23. And so there is a close association between these inflammatory markers, these neurohormonal abnormalities that you see in heart failure, as well as the hemodynamic abnormality. And all of them played a critical role. And one needs to tackle each of these when one looks at diagnosing cardiorenal syndrome early and in managing these patients. A word about what happens if you take type 1 acute cardiorenal syndrome, heart failure. There's a patient who has heart failure. There's sympathetic activation. There is the RAS system activation. There is the hemodynamic mediated damage, the decreased perfusion, but more importantly, the increased venous pressure. Add to this is the issue of diuretics. The need for diuretics and AC inhibitors, both of which will contribute to some amount of renal damage. So all these act to produce type 1 cardiorenal syndrome. Type 2 is, as we discussed, is chronic heart disease resulting in progression to CKD. And there is both a low cardiac output, inflammation, arterial calcification, chronic hypoperfusion, increased venous pressure. And this over a period of time will result in CKD, as well as the progression to CKD itself will worsen chronic heart failure. So it's a vicious cycle where anemia, hypertension, electrolyte imbalance, all of these, and we did discuss about some of these inflammatory markers like the FGF23, which is increased and probably plays a very important role in the chronic heart disease that takes place. Type 3 cardiorenal syndrome is the renal-cardiac syndrome, acute kidney injury, again through multiple mechanisms, electrolyte and coagulation abnormalities, hypertension, sympathetic activation, RAS activation can result in acute heart dysfunction. Type 4 is chronic renal-cardiac syndrome, again CKD stage 3, 4, CKD 5, 6, through its various effects that we've already discussed, can result in LV dysfunction. And we very often see that a few months down the line after transplant, all these come back to normal. And finally, type 5, which is systemic diseases, primarily sepsis, diabetes, amyloidosis, or vasculitis that affects both these. And it's difficult to say which one contributes more, but each of those is affected, and one may worsen the other two. Finally, pathophysiologically, there is probably a common pathway in which fibrosis may be the key pathogenetic process. Myocardial remodeling occurring after cardiac injury, where fibrosis is a key issue. So also tubulointerstitial fibrosis might be taking place. And one might look at some of these antifibrotic agents, aldosterone antagonists, and the newer one, phenylenedione, which does not increase potassium and may play a critical role in preventing fibrosis. The role of imaging and for cardiac and renal dysfunction diagnosis, I think we all do use this, whether it's an echocardiogram, Doppler, ultrasound, or chest radiograph. These are things that we as cardiologists would use to look for hemodynamic dysfunctions, which could in effect affect the kidneys too. And so also when you look at somebody who presents with acute or chronic kidney disease, some of these ultrasound or Doppler tests might be of use. What about the role of biomarkers in cardiac dysfunction? It's common for us to use troponins and BNPs. ST2 is again something that seems to correlate with fibrosis. In terms of kidney biomarkers, this is not something that is commonly used. Maybe Dr. Kerr will enlighten us on this. The commonly used tests like creatinine or albuminuria have a certain delay in going up, and early intervention may be precluded in this if you were to look only at that. And maybe there is a role for some of these other newer biomarkers in diagnosing early cardiorenal syndrome. The role of SGLT-2 inhibitors, I think Dr. Kerr will discuss. So my take-home message is this: distinguishing true acute kidney injury from functional causes for fluctuation in serum creatinine in the context of diuretics for acute decompensated heart failure is critical in ensuring delivery of goal-directed medical therapies early in its course. And I think that is important for us to remember. Identifying the factors contributing to diuretic resistance is a key step in optimizing decongestion in CRS. Biomarkers of cardiac and kidney injury represent a new dimension in the diagnostic algorithm in evaluating heart failure with impaired kidney function or for prognostic value in acute and chronic CRS. And a multidisciplinary approach is required for appropriate drug therapy, including antifibrotic therapy. And a cardio-nephrology multidisciplinary approach is essential in the joint management of patients with CRS, with an emphasis on core outcome measures based on patient and physician priorities. So I'll stop at this point, and maybe we will go on to the next part of the presentation.
Thank you, Thomas, for finishing in right time and making a complex subject very simple for the understanding of the audience. I think we'll take up some questions and comments after the end of the next session. So may I now introduce Dr. Vijay Kher with the Mithilesh, Mithilesh? Dr. Mithilesh. Hello.
Sir, there is a slide, there is a screen of live.
Yeah, actually, I have put my slide. So you want me to take it off?
Unshare.
Okay.
You don't share your slides now.
Okay. Let me unshare.
Yes, sir.
Okay,
Yeah,
Dr.
you have it.
We have the next speaker, Dr. Vijay Kher, who is the chairman of the Nephrology and Renal Transplant Medicine, Medanta, the Medicity, Gurgaon. He was the past president of the Indian Society of Nephrology. He has set up a successful nephrology department at Seri Kashmir Institute of Medical Sciences, Srinagar, SGPGI, Lucknow, Apollo Hospitals, New Delhi, Fortis Hospital, New Delhi, and Medanta, the Medicity, Gurgaon. Actively involved in the scientific program and research agenda nationally and internationally, like KDIGO, AKIN, work group, etc. Published about 226 papers in peer-reviewed journals, 43 book chapters, including Oxford Text of Nephrology, and edited 12 books. So with this, we'll be listening to Dr. Kher with his wide experience and his approach to the management of cardiorenal syndrome in diabetes mellitus, with special reference to SGLT-2 inhibitors. Dr. Kher, please.
Thank you, Dr. Mishra, for that kind introduction. Let me see. Can I get my slides? Yes. Can you see my slides?
Yes, sir.
Okay. Thank you, Dr. Mishra, for that kind invitation, and I must thank Intas for this opportunity. It's always a pleasure to be talking to a large gathering of cardiologists, physicians, and nephrologists on something which is happening newer in the area of cardiorenal syndrome. And over the last 5 to 6 years, there have been newer drugs which seem to be making a paradigm shift in the management of these patients. We know that diabetes, the commonest cause of death is cardiovascular disease, and diabetes seems to be the mother disease on which chronic kidney disease and cardiovascular diseases travel together. And in fact, when you look at the deaths in patients with diabetes, when you look at the vascular or non-vascular death, a 50-year-old diabetic actually loses about 6 to 7 years of life by early death in comparison to somebody who is not diabetic. And most of these deaths may be both vascular as well as non-vascular. Dr. Thomas was talking about the connectivity between the crosstalk between the kidney and the heart, and it seems that diabetes is the disease where both chronic kidney disease, which occurs 50% of chronic kidney disease is related to diabetic nephropathy. Initially, we were thinking that probably in India that's not so common. Glomerulonephritis and other diseases may be more common, but now it is quite evident. Every day in my clinic, I would see chronic kidney disease. 50% of these chronic kidney disease patients are diabetic patients. And same, I'm sure the cardiologists look at cardiovascular disease, and I'm sure. And this was sort of realized long time back by Richard Bright in 1836, that those patients who have albuminuria, and at autopsy, he found that the hearts of these patients who had albuminuria, proteinuria in their urine was actually hypertrophied. And he sort of hypothesized at that time that there is something in the these patients who have albuminuria, how kidney disease, there is an increase in the hypertrophy of the heart. And this cardiorenal connection was known to Richard when you look at the causes of death in patients with chronic kidney disease, and Dr. Thomas mentioned about it, that 50% of deaths in patients of chronic kidney disease is related to cardiovascular mortality. And that is the commonest cause of death in patients of chronic kidney disease. And this starts very early, even small decrements in GFR. And you can see that this is GFR heat map, where you have GFR going down from stage 1 to stage 5, and you have albumin-urea shown on the x-axis with albumin creatinine ratios of less than 30 milligrams, 30 to 300 milligrams, which is overtly increased, moderately increased albuminuria, which was called microalbuminuria in the past, and more than 300 milligrams of albumin excretion in 24 hours, which is called overt or severely increased albuminuria. And you can see that even small increases in albuminuria by itself in a GFR of 90 to 5, you can see this is the reference marker, and 1.5 times, even when in the normal albuminuric range, if you have albumin less than 10 or you have albumin more than 10, your mortality, the cardiovascular mortality increases, and it progressively increases as the albumin creatinine ratio increases or the GFR keeps on going down. And same is true for all-cause mortality, and the numbers given are the relative risks across the GFR categories as well as albuminuria categories. And this is for kidney failure, development of end-stage kidney disease, and you can see that. Look at this number here. That patients who have ultimately a GFR of 15 to 30 ml will develop huge amounts of end-stage kidney disease, very, very high risk for development of kidney disease. And this is for progression of kidney disease. So you can see that the relative risk for mortality, cardiovascular mortality and all-cause mortality is increased even with smaller. And this is shown here in a graphic fashion here, that this is GFR from 120 ml going down to 15 ml. And this is the hazard ratio for cardiovascular mortality. And you can see that the sweet spot is between the GFR of 75 and GFR starting down from 75 ml to 15 ml. You can see the progressive increase in the cardiovascular mortality. Same is true for albuminuria on the right-hand side. And you can see that even albuminuria, 30 albuminuria is considered to be a normal albuminuric state. But you can see that even in this normal albuminuric state, you find that there is an increase in mortality. And obviously, when you have microalbuminuria or moderately increased albuminuria or severely increased albuminuria, the mortality increases high. The reason why I'm saying this is that now we have drugs which can affect both at the albuminuria level as well as protecting the decline in the GFR in these patients. So you can have, and therefore one might be able to intervene in the overall mortality in these patients and decrease cardiovascular mortality as well as all-cause mortality in this patient. And this reflects, actually, this is from the US, RDS data from the US, and this is the normal population. These are different males, females, whites, and blacks. This is the mortality chart, annual mortality chart for range of 25 years to 85 years. And these are dialysis patients who are undergoing 3 times a week dialysis. And you can look at, this is a 25-year-old person, a normal person, 0.01 chances of mortality. Whereas look at the mortality in this 25-year-old man, he becomes almost like an 80-year-old person. The same kind of mortality. So 10 to 100-fold increase in mortality. So 25 years. This is a person who is undergoing 3 times a week dialysis. Very high chances of dying from mortality. So therefore, intervening in these patients, not allowing them to reach to end-stage kidney disease would be a target. And I think we will talk about that there are therapies now available which might change all this kind of thing, 10 to fold increase in mortality. So it's important to understand this for what I'm going to talk about in now. Dr. Thomas mentioned about this, that the risk of heart failure and chronic kidney disease increases with increasing stages or deterioration of kidney function. As you see, stage 1 to 2 you can see that lower levels, but then progressively increase in whether you're talking of systolic or diastolic, so preserved heart function as well as reduced ejection fraction. When you look at all of them are increased with progressive deterioration in renal function. And there is 41% patients with chronic kidney disease are present in heart failure, whether it is preserved or it is low ejection fraction. 41% of patients will have chronic kidney disease in these patients. So there is a sort of high incidence of heart failure in patients with progressive kidney disease. And this is shown in this slide, and you can see that this is GFR going down from 100 ml to about 10 ml. And this is the prevalence of coronary heart disease, cerebrovascular accidents, and heart failure. And you can see that in pre-ESRD stages, it's higher. And as the CKD progresses and reaches end-stage renal disease, the incidence and heart failure remains the commonest cardiovascular morbidity in patients of chronic kidney disease. And this was talked about, the crosstalk between the heart and the kidneys, and these are mediated through either hemodynamic mechanism, neurohumoral, hormonal changes, and then some of the similar kind of effects which happen in the heart and the kidney: malnutrition, cachexia, wasting, chronic inflammatory activation of cellular immunity, which with the markers of interferon and other markers with TNF alpha, increasing fibrosis both in the heart as well as in the kidney, which Dr. Thomas so elegantly described, and the changes in the bone mineral disorders, acid-base disorders, anemia, and aggravation of that leading to heart failure, as well as progressive anemia occurring in patients of chronic kidney disease. So the cardiorenal disease in diabetics therefore produces progressive damage in heart as well as kidneys, leading to very high cardiovascular and overall mortality in these patients. And therefore, it's important that we should have treatments which must intervene very early in this group of patients, because the mortality remains extremely high despite the current standard of treatment, which is happening in these patients with ACE inhibitors, beta blockers, control of blood pressure, control of diabetes and all. Despite that, the mortality continues to be high in these patients. Repeated hospitalizations are very common in patients with kidney disease and heart failure. And therefore, newer therapies might leverage us some gain if we intervene early, especially attacking the mechanistic, common mechanistic pathways which Dr. Thomas was talking about. And therefore, it appears that the benefit might appear very early in patients if we intervene early, and you might be able to have a significant impact on the mortality and morbidity in these patients. And even in late stages, it's been seen that there is reduction of both mortality and morbidity in these patients. So what is the current kind of standard of care that we use in these patients? We obviously control blood pressure, use statins to lower the cholesterols and the lipids, the mineralocorticoid receptor antagonists, and Dr. Thomas was again talking about the finerenone and the non-potassium reading and newer finerenone. And they've been both found to be effective. Cardiologists have been using it for some period of time. Nephrologists were not using it. But there are studies now which have shown that this also reduces the progression of kidney disease as well as reduces albuminuria in patients of chronic kidney disease. And ACE and ARBs obviously have been used both by cardiologists and nephrologists. For nephrologists, there have been no other drugs except for using ACE and ARBs for preventing progression of kidney disease and decreasing albuminuria. However, with progressive kidney disease, they're used especially because of the adverse effects of hyperkalemia. So the optimal use of ACE and ARBs gets limited many times in these patients. And for glycemic control and the cardiovascular, metformin remains the standard kind of backbone of therapy on which newer therapies have been added. And let's see if there is a newer form of therapies which will help us in lowering the morbidity and mortality in patients of cardiorenal syndrome. This is the effect of atorvastatin or reduction of lipids in patients of heart disease. And this is, you can see the cumulative hazard ratio for cardio risk reduction occurs about 37% with the SHARP trial, especially in patients not on dialysis, there has been an effect on mortality in patients with chronic kidney disease. These were patients who were so difficult to demonstrate an effect of lipid reduction, but SHARP trial did demonstrate a significant effect reduction in mortality with using atorvastatin and estimate in patients with chronic kidney diseases prior to dialysis. And this is the effect of ACE and ARBs in these patients. And you can see that even in patients with chronic kidney disease and heart failure, you can see that there is reduction in hospitalization in these patients. And these are also the results of event rates are decreased in these patients. And this was on captopril. And beta blockers have shown whether you have a GFR less than 45 or you have a GFR 45 to 60 or more than 60, you can see that there is a benefit related to hospitalization and mortality in patients with worsening heart failure. And kidney function, degree of kidney function doesn't seem to provide any alteration in the amount of benefit that accrues from it. And this is mineralocorticoid. And in early stages of CKD, this has been shown to, again, provide a better survival. However, in stage 4 and 5, when the effect of spironolactone may not be evident, obviously you do not see that kind of an effect. And many patients, especially with a GFR less than 30 ml, are usually excluded for large studies, and therefore you may never be able to study them in a primary event kind of a thing. It's only this sub-analysis of some of these large trials that you get to see data of stage 4 and stage 5 kidney disease. And ARNI, which is again another drug which is available for the cardiologist for use in patients with heart failure and has shown significant one in the Paragon trial. And this is whether you have a GFR less than 60 ml or you have GFR more than 60 ml, you can see that the benefit effect on the composite MACE, whether it is cardiovascular death or hospitalization for heart failure, cardiovascular death, or individual heart failure hospitalization or all-cause mortality, you find that there is about 20% benefit with use of ARNI in these patients. And these were patients who already were on ACE and ARB. So there was a 16% benefit. So you have about 36 to 37% benefit by using ARNI in these patients. And this was seen that actually patients with CKD had a better absolute risk reduction of 3.7 versus 2.1 in these patients. And so that's significant impact of ARNI in patients of heart failure, especially those with kidney dysfunction, which is not uncommon in these patients. So especially in stages CKD 1 to 3, there is a reasonable strong evidence for use of many of these drugs. However, as I said, that most of the studies exclude patients with GFR less than 30. So the evidence for their benefit in stage CKD 4 is usually absent or is extremely weak in these patients. So what's the evidence that the SGLT-2 inhibitors, at least over the last 5 years, there have been multiple studies which have demonstrated benefit of. Now, just 2 slides to understand the mechanistic ways by which SGLT-2 inhibitors act actually, and you can see that in diabetes, there is an overexpression of SGLT-2 sites, and that leads to increase in sodium and glucose co-transport. Glucose transport increases, and with that, the sodium transport also increases. So there is less delivery of sodium to the macula densa, and which is the distal convoluted tubule, and that leads to there is a macula densa is in close interaction with the glomerulus. The afferent arteriole dilates, and that leads to increase in the hyperfiltration. The GFR goes up, as well as the glomerular pressure goes up. So there is increased intraglomerular pressure and there is increased hyperfiltration. And that's what leads to albuminuria, progressive decline in GFR, and a progressive deterioration in renal function. Now, so there is hyperfiltration. Now, what SGLT2 inhibitors do is that they do not allow, they go on and occupy the SGLT2 sites, do not allow glucose to be reabsorbed. So with the glucose reabsorption not occurring, there is sodium reabsorption also, which doesn't happen. And so there is greater distal delivery of glucose as well as sodium to macula densa, and the macula densa will lead to efferent arteriolar vasoconstriction, and the intraglomerular pressure goes down as well as the GFR goes down. And this is important to understand that this decline in GFR initially, which happens in these patients, might raise the serum creatinine when you use SGLT2 inhibitors in these patients. And that might sort of cause a scare amongst the patients as well as amongst the doctors, and usually do not discontinue SGLT2 inhibitors. This was the same kind of thing which happens with ACE inhibitors as well as with ARBs, that they would cause slight increase in serum creatinine. Usually this is reversible, and those patients where you continue to use SGLT2 inhibitors, ultimately they have a slower decline in GFR, and the serum creatinine at the end of 3, 4, 5 or many years later, you will find that the group which has used SGLT2 inhibitors will have a lower serum creatinine in comparison to those where SGLT2 inhibitors have not been used. Diuretics are very commonly used in patients with heart failure and patients with kidney disease, but they have not been documented to provide any benefit as far as mortality is concerned. Whereas SGLT2 inhibitors also cause natriuresis, cause decrease in the sodium content in the body, but they produce significant impact on the mortality and cardiovascular mortality in these patients. The difference between the diuretics and SGLT2 inhibitors is that in diabetic patients, there is an increase in sodium. As I said, the SGLT2 receptors are overexpressed. There is an increased absorption of glucose. There is also increased absorption of sodium, and that leads to increase in interstitial or extracellular fluid volume, which is distributed into the interstitial compartment and the intravascular compartment. And you can see that with SGLT2 inhibitors, there is a far greater decline in sodium, a far greater decline in interstitial volume. So the natriuresis that occurs, that leads to decrease in total sodium in the body, as well as in the extracellular compartment, as well as decrease in the interstitial volume. The intravascular volume is not decreased to that extent in comparison to diuretics, where the impact on intravascular volume is much higher in comparison to the interstitial volume in these patients. So therefore, SGLT2 inhibitors might provide a different mechanistic. The decrease in intravascular volume increases the sympathetic neurohormonal activity, and that might be leading to adverse effects which are contributing to increase adverse effects related to diuretics, whereas those effects are not seen. Usually a downsiding of neurosympathetic activity with SGLT2 inhibitors. So the distinguishing features of SGLT2 inhibitors are that they cause weight loss because there is loss of glucose and obviously calories from the body. They cause blood pressure reduction, all kinds of blood pressure, systolic and diastolic blood pressures go down, and that's related to the natriuretic effect. The uric acid also goes down, and that's related to that there is increased sodium delivery to the distal, which will increase the urate expression on the urate1 and GLUT9, and that leads to tubular urate transporter inhibition, as well as increase in the uric acid excretion from the GLUT9, which is facilitative for glucose transporter for the distal absorption at the distal tubule. Usually SGLT2 inhibitors don't cause hypoglycemia, because as the glucose levels start going down, the glucose sort of inhibition of the further glucose glycosuria stops, and therefore there is no further decline in the glucose level. So hypoglycemia is not common in patients who are on SGLT2 inhibitors. We talked about the slight decline in GFR at the initial part, usually reversible in about 4 to 6 weeks time. And if you continue and you take care of the volume depletion in these patients, then you should have a progressive decline in slower decline in GFR in these patients. And these are multiple studies which have documented that SGLT2 inhibitors have both cardiorenal benefits. And that's why these become extremely useful drugs which act in both kidneys as well as in the heart. And we've been talking about the cardiorenal syndrome. And you can see that the EMPA-REG, the heart failure, hospitalization for heart failure, 35% risk reduction, cardiovascular death, 38% risk reduction. And the major, these were secondary outcomes. These were not the primary. The cardiovascular outcomes were the primary outcomes, which were for many of these studies. And you find that the kidney outcomes were secondary outcomes, but all of them documented that there was a benefit of an equal, whether it is CANVAS program for canafloglazine, declared to me for dapagliflozin. So this seemed to be a class effect. Ertafloglazine, the Vertis CV trial actually showed some benefit in heart failure, but not a significant benefit in cardiovascular mortality. And the renal effects also seem to be slightly downward. However, Credence trial, which was a primary trial for looking for major kidney events, and you can see that the MAKE had a 30% reduction of either ESKD, doubling of serum creatinine, or death from kidney disease or from cardiovascular death. A significant reduction of 30% mortality in patients who for renal outcomes. And the secondary outcomes in this trial again showed similar kind of effects as was seen in EMPA, DAPA, and other trials as well. 31% reduction in cardiovascular death or hospitalization, heart failure, 3P MACE, 20% reduction. Hospitalization for heart failure was 39% relative risk reduction, and composite kidney points and points were 34% risk reduction. So you can see that there was a decline in all-cause mortality, cardiovascular mortality, as well as renal endpoints were decreased by about 30%. DAPA-CKD was a study which looked at both diabetics as well as non-diabetics. About 35% of patients in this trial were non-diabetics as well. And they had albuminuria going from 200 milligram to 5 grams and GFR going up to about 20 ml per minute. Most other trials had GFR going up to about 30 ml or so. And this trial showed that whether you had diabetes or you didn't have diabetes, the impact on the ESKD, 50% reduction of GFR or renal or cardiovascular death was about 39% relative risk reduction. Huge impact. And this opens up another vista that this drug is effective not only in diabetics, but also in non-diabetic patients who have mild degree of albuminuria. It becomes an important drug which produces significant benefit for renal outcomes. And the secondary outcomes in this trial again demonstrated the effects which were shown in the primary outcomes in the other trials. 44% relative risk reduction of this was the renal effects, the cardiovascular, 30% reduction of cardiovascular death or hospitalization for heart failure, and all-cause mortality of about similar. And DAPA heart failure and has again demonstrated whether patients were on diabetic or not, you have again important risk reductions both for worsening heart failure, cardiovascular death, and total heart failure with cardiovascular death events of about 25%. The quality of life, other scores also, composite kidney outcomes, 30% reduction, and all-cause mortality about 17% reduction. EMPRA reduced, which also looked at again in patients with or without type 2 diabetes, similar kind of effects. whether you looked at the primary composite outcomes or secondary outcomes in GFR or at the heart, you had similar kind of effect. So it seems that most of these SGLT2 inhibitors have a class effect on beneficial effects in heart failure, for cardiovascular mortality and cardiovascular death, as well as renal benefits in patients, whether they are diabetic or they are not diabetic. So these sort of suggest that SGLT2 inhibitors will reduce renin-angiotensin, aldosterone-induced neurohumoral and sympathetic activation is decreased. There is reduction in fluid overload, oxidative stress, inflammation, and fibrosis. There are a lot of mechanistic things that are being talked about, and I think we will not get into the details of these mechanisms of actions of SGLT2 inhibitors. They seem to be, the anti-glycemic effect seems to be in only an extremely small effect of SGLT2 inhibitors, and they seem to be not sort of diabetic drugs. They seem to be organ protective drugs. Actually, they protect the stressful cells and produce homeostasis as well as increase survival in patients, especially with cardiorenal syndrome. So these drugs open up a new paradigm shift in the management of patients with heart failure and patients with kidney disease, whether patients are diabetic or patients are not diabetic. There is improvement in vascular endothelial function, both in heart and kidney. And obviously there is improved cardiorenal hemodynamics and cardiorenal protection. As I said, that clinicians have to think of them as organ protective drugs rather than as anti-hyperglycemic drugs. And that opens up new vistas for this kind of management. And as I was talking about, that if we use these drugs early enough, and in fact, the benefit starts in about 2 to 3 months' time. In fact, the lines for both mortality as well as ESKD start very early, and therefore you can see starting benefits of these drugs very early in the course of the treatment of these patients, and therefore these drugs probably need to be started early. As we start gaining more experience with the use of these drugs, we will learn how to use these drugs effectively. So, ladies and gentlemen, let me conclude that for cardiorenal disease, especially in diabetics, although I talked about non-diabetics as well, there is a new opportunity for treatment of cardiorenal disease, and earlier management is definitely needed to produce a marked impact on the huge cardiovascular mortality and morbidity in patients with cardiorenal syndrome. And I feel that these drugs look like to be the organ protective drugs for heart and the kidneys especially, although they may have other benefits as well, which need to be sort of probed and proven as yet. Thank you very much for your patient hearing. Thank you.
Thank you, Dr. Kher. You can answer your slides, Dr. Kher.
Yes.
Yeah. So for your extensive coverage about the management and especially the SGLT2 inhibitors, I think there may be a lot of questions. Dr. Mithilesh, can you send the questions to my chat box so that we can share these questions with the speakers? Dr. Mithilesh?
Yeah, I already shared in your chat box.
Achha, okay, let me see. This is one question from Dr. Umesh Chauhan. That is, his question was target hemoglobin in patients with CKD and heart failure.
I think we should target hemoglobin to more than 10 grams in patients with heart failure. As the right. better is usually in patients of chronic kidney disease. The general guidelines, KDIGO guidelines, suggest that the target hemoglobin should not go beyond 11.5 or 12 grams. So usual target for hemoglobin is 10 to 11 grams. In patients with heart disease, I usually try to keep the goals towards 11 grams or so by using obviously iron supplementation in these patients if they are iron deficient, which is common in patients with these group of diseases. And then if the erythropoietin is needed in these patients, then we would use erythropoietin to target around 10 to 11 grams.
So there is another question. SGLT2 inhibitors now proven to be beneficial in non-diabetic heart failure and CKD. So do you recommend SGLT2 inhibitors in all patients with heart failure and or CKD irrespective of the diabetes status?
I think the evidence does suggest that. And as far as CKD patients, I don't treat heart failure primarily, and Dr. Thomas might be able to sort of answer that question for heart failure. But I have started using this in non-diabetic kidney disease as well, patients who have some degree of albuminuria and have deteriorating renal function. Then I would definitely use this drug in addition to using ACE and ARB. So now, as a nephrologist, we have another drug available in our armamentarium to slow down the progression of kidney disease as well as reduce albuminuria in addition to ACE and ARBs. So we could combine ACE or ARB along with use an SGLT2 inhibitor on top of it to reduce at least the chronic kidney disease. And I'm sure this is going to be beneficial in heart failure. And Dr. Thomas might sort of want to talk about the heart failure primarily. But I think the evidence is there.
Dr. Thomas?
Yeah, I would totally agree with that. I think the real challenge is, of course, the cost and compliance. If you were to look at an ARNI and an SGLT2 inhibitor, and I think the generics is certainly an area where that helps. Having said that, I think in my own practice, if it was a choice between the two and the renal parameters were normal, it would be an ARNI before I use an SGLT2 inhibitor. But on the other hand, if I was to see a certain amount of renal dysfunction, creatinine close to 2 or 2.5, clearly I would favor starting this patient on SGLT2 rather than using an ACE/ARB or ARNI.
Same thing. Somebody asked the same thing. Which agent do you prefer first in heart failure? ARNI, beta blocker, SGLT2, diuretics?
I think a beta block. I think those are standard drugs. You cannot have a heart failure patient who's not on a beta blocker, who's not on a statin. So I think that is absolutely essential. And I would say if he can afford it, rather than ARB or an AC inhibitor, should be on an ARNI. And I would think that those form the basis of treatment of heart failure. I think the next step would be an SGLT2 inhibitor, maybe as an add-on, or if you are in a situation where you have certain, say, a renal dysfunction, maybe an SGLT2 at that stage.
Any other question? I don't find any other question. Mithilesh, are there any other questions?
Yes, I will share again.
Because I don't, in my chat box, I don't find any other question. Can you share if you have any other question?
Yes, sir, I will share again.
Maybe while we are waiting for those questions, Dr. Kher, I think hyperkalemia being one of the things that worries us when we use a mineralocorticoid antagonist or an ACE/ARB. Where do you see these potassium? I mean, there are a lot of agents which are coming on the block which remove potassium, maybe as where do you see that coming into routine practice where you would add one of those drugs along with, say, an ACE or ARB or a mineralocorticoid antagonist?
Yes, I think that's a good question. And I think I mentioned that hyperkalemia or the fear of hyperkalemia obviously doesn't allow us to optimal use of ACE ARBs, or it will happen same with ARNI as well, that there is some adverse effects of increased potassium. And I think these newer long-term hypokalemic agents like petromar or zirconium silicate, fortunately, zirconium silicate is likely to get into the Indian market very soon. Unfortunately, all these drugs are new and the cost is going to be prohibitive. And I don't know how many of our patients will be able to manage to use these drugs. But I hope that the generic industry will be again active and will produce these drugs in the country itself, and the costs would go down, and that allows us to use these drugs in large majority of our patients. And that's going to be, but those drugs are definitely been proven to be useful in allowing us to optimally use mineralocorticoid receptor antagonists as well as ACE and ARBs and probably ARNI as well. And that does happen that with progressive renal dysfunction, hyperkalemia will limit that. And the availability of these two forms of drugs, at least one of them is coming into the market very soon. Petromar may be in the market maybe another 6 months to a year or so.
There's another question for Dr. Thomas. When to consider ionotropic agents in cardiorenal syndrome?
Well, I think if you're talking about an acute heart failure, decompensated heart failure, at that point, I think one needs to look at whether one is looking at an inotrope or whether you're looking at a vasoconstrictor, depending on the blood pressure. So whether levosimendan is the drug that you would look at that point, or is it NORAD or vasopressin, which you might be doing. So I think an acute decompensated heart failure, when you have a low blood pressure as well as congestion, often many of these patients need to be on, say, a diuretic infusion plus an inotrope or as a vasoconstrictor also. So I think it's more in acute decompensated heart failure that you would look at these drugs.
Which agent is better in reducing congestion, diuretic or SGLT-2 inhibitors? This slide has been shown by Dr. Kher.
Yeah, I think in an acute heart failure and with acute kidney injury and all that, obviously you would want the intravascular volume to go down to some extent to produce decongestion quickly.
Symptoms.
So I think, symptoms improve. So I think I would use diuretics. SGLT-2 inhibitors may be used once the patient stabilizes to some extent, is better, and then one would use SGLT-2 inhibitors in those kind of things. And same would be for ARNI as well. So I would stabilize the patient with use of diuretics, produce symptom relief as well as improvement in his clinical state, and then probably introduce SGLT-2 inhibitors.
Potassium binders, a question that has already been answered. Can we use SGLT-2 inhibitors in patients with renovascular hypertension? There is no such study. Dr. Kher?
No, I don't think these are drugs which have an impact on progression of kidney disease, on albuminuria, on cardiac protection, decreasing cardiovascular mortality. But I think renovascular hypertension is a different disease, needs different management, not SGLT-2 inhibitors.
Role of ARNI in type 4 renocardiac syndrome with ESRD.
Well, actually, ARNI have not been studied in ESRD. See, in the Paragon trial, the exclusion was GFR less than 30 ml. There is a trial, HARP trial, which was done with a GFR going up to about 20 ml or so. This was a small trial done in UK, where they looked at some 300 patients with stage 4 kidney disease and with heart failure. And they found that there wasn't any benefit as far as this was a small study, so there wasn't any kind of significant difference as far as mortality benefits were concerned. But this was a safe drug to be used in stage 4 kidney disease. So I would guess that as we gain experience with use of ARNI and all, like there are larger number of patients now on dialysis who are on ACE inhibitors as well as ARBs for control of blood pressure as well as documenting cardiovascular protection, because these patients might be living for longer period of time and are at the highest risk of cardiovascular mortality. As I showed you, that dialysis patients are at a 10 to 100 folds increased cardiovascular mortality. So to reduce that cardiovascular mortality, I think these drugs remain, ACE and ARBs are being used in patients who are on dialysis. I don't have any data as yet of ARNI, so we don't know whether ARNI would produce the same kind of benefit. We need more studies in that fashion. Same is going to be used with SGLT2 inhibitors also. At the moment, we don't have that kind of data because they've not been used below 20 ml of GFR. So we will need more studies in that area to see whether they produce cardiovascular benefit in that category.
How common is the UTI with SGLT2 inhibitors in Indian patients? What is the concern?
No, I think UTI is not genital infections, especially fungal infections are common.
Urogenital infections.
Yes, they need to be, they are more common, but otherwise urinary tract infection, I haven't found it significantly very different in patients who haven't had previous urinary tract infections. See, somebody who has had previous urinary tract infections, these drugs may not be the best drugs to be used in those patients, but you need to educate your patients for fungal infection and cleaning the genitals on a daily basis and looking for genital infections, because sometimes you may have hidden infections in these areas and these can spread. And Fournier's gangrene and all have been described in the literature. They're uncommon, but people need to be educated and aware that they can happen in these patients.
Hygiene, improve the urogenital hygiene.
Yes,
what
yes.
is the EGFR below which you should not use an SGLT2 inhibitors? Because
at the moment,
because it can be used to below 20. What is your opinion, Dr. Kher?
No, at the moment, I think the guidelines suggest that they should not be used below 30 ml because most of the studies, Credence went up to 30 ml. That was the primary renal trial. DAPA-CKD went up to 20 ml of GFR. However, there are sub-studies which are the data coming from sub-studies in patients who were started at 30 ml of GFR during the follow-up of 3 to 4 years. Many of these patients had declining GFR and the GFR went down to they continued to be on SGLT2 inhibitors. So that kind of data is appearing, and it appears that these drugs are safe and produce benefit of cardiovascular protection. Even in patients with GFRs which are less than 30 ml or so. But we need more robust data for that.
Thomas, use of SGLT2 inhibitors in elderly heart failure patients.
I honestly don't think that is a contraindication in my patients. And I mean, many of my patients with heart failure are in the elderly group. So I don't think there's any data to suggest that it's contraindicated. While we are talking about this, maybe I could just add that very often in clinical practice, whether you're using a SGLT2 or an ARNI, once you get them on that, the dosage of the diuretics tend to come down. Yes. And I think that's a very, very important thing to remember to do and not keep your patients on the same dose of diuretics when you started with them.
You know, I think I would add another thing, that one is that you must optimize, sort of reduce the dose of diuretics when you introduce ARNI as well as when you introduce, and when you are introducing, say, using a diuretic, an ARNI, as well as you want to introduce now an SGLT, don't do them together. Give usually some time gap of about 4 to 6 weeks, because otherwise you might find sudden decline in GFR, because ARNI also will cause some sudden decline in GFR, and SGLT2 also might, and the creatinine might go up, and that might scare the patient as well as the clinician of using it. To optimally use these drugs, if you have a patient of heart failure in whom you had used higher doses of diuretics and now you want to introduce ARNI, I would reduce the dose of diuretics to some extent, optimize the dose of ARNI to an optimal dose, give yourself another 3-4 weeks. And then if you want to introduce an SGLT2 inhibitor, then use an SGLT2 inhibitor in that.
So there is a question. SGLT2 inhibitors reducing aging process, keep the patient relatively young. Is it true? Is this statement?
There are a lot of effects of SGLT2 which are being investigated, and newer things are sort of being looked at. Process of aging, process of fasting, in anti-inflammatory effects and others. So we don't know. I think we need more data on those kind of things. But stay tuned. Yes. The pleiotropic effects.
Yes. And Thomas, I have one question. See, as rightly pointed out by Dr. Kher. So when we manage a patient like this is a common thing amongst the cardiologists and physicians, like a patient of idiopathic dilated cardiomyopathy or ischemic cardiomyopathy with a borderline hypertension, systolic blood pressure remaining in a range of 90 to 100 millimeter of mercury. Those kind of patients, we whether we start small dose of ACE-ARB or ARNI, whatever, then you cannot up-titrate. You find that the blood pressure is coming down, his urine output is coming down, his creatinine may be going up. So is that kind of patient population, say for example, beta blocker you cannot up-titrate, you have to be on a smaller dose. Can we safely start SGLT2 inhibitors in those kind of patients? What is your opinion?
Yeah, I think that's a good point. Often you find that these are patients with borderline blood pressure, especially if they have associated coronary disease. You don't want their pressures to drop too low because that would be counterproductive. So I think in these situations, SGLT2 would probably be a better drug to start with rather than an ARNI. A beta blocker, I'm one of those who use a fair bit of beta blocker, and I'm not scared of the blood pressure effects of a beta blocker because I think its effect in heart failure is tremendous. So I go with the beta blocker. I don't worry too much about the blood pressure. But when I'm using, say, an ACE-ARB or ARNI, I would like a little bit of headroom to go up on my dose. Otherwise, I think SGLT2 might be a better option.
So I think, Dr. Mithilesh, if there are no other questions, and I must thank both the speakers for doing an excellent job. And with the concluding remarks, I would like to say, which has already been said, SGLT2 inhibitors, regardless of how their actions are envisioned, it is now critical for physicians to reconceptualize them as organ protective agents rather than glucose-lowering drugs. The anti-hyperglycemic action of these drugs represents a tiny fraction of their broad portfolio of efficacy, which when fully exercised cause an adaptive reprogramming of stressed cells in a manner that promotes homeostasis and survival. So it is a drug which will be a very important drug in the armamentarium of cardiologists, diabetologists, and nephrologists. I'll just put one word. In 2017, there was a national conference of the Endocrine Society of India in Bhubaneswar, where I was chairing a session as a cardiologist in SGLT2 inhibitors. There are all top-class endocrinologists in that session. When I told that this drug is going to be the drugs for the cardiologist and nephrologist rather than endocrinologist, they were laughing at me. But see, lo behold, it has become a drug for the cardiologist and nephrologist more than endocrinologist. So with these few words, I give thank you very much. Thank you, everybody, all the speakers, the Intas Pharma, especially Mr. Amit Arora and Dr. Mithilesh, and all the audience who have participated in this session. Back to Amit.
Thank you, sir. And I would like to offer the vote of thanks on behalf of Zenith, which is division of Intas Pharmaceuticals, makers of Dapavel. Dapavel, as you said, is a generic dapagliflozin. I must thank all the participants today who joined in from all across the country. We had more than 800 doctors today who have logged in and listened to this conversation and wonderful presentations by our speakers. Dr. Thomas, who made the subject of cardiorenal syndrome in such a simplistic way, and we had Dr. Vijay Kher, who presented the pharmacological aspects of managing cardiorenal syndrome, in particular diabetic subpatient, and with focus on SGLT2 inhibitors. And there are a lot of insights which were given from both the speakers. And Professor Mishra sir, we are always thankful to you for your guidance and your way forward that you show to us and what kind of topics we keep in our programs. So we are really grateful to you for that, and thank you very much for being part of today's program. And we have Dapavel, which is dapagliflozin, costing very low, and we have available Dapavel in our mono cartons with patient advice, which is mentioned on each and every pack. And Dapavel M, we are going to be soon launching, which is again less costly than even Dapavel, plain drug. So with this, I thank you all for your participation today, and good night to all of you from here at Intas. So thank you very much, and good night.
Thank you very much.
Thank you, sir.